Yes. So this is an interesting session lineup about gonioscopy, and I have introductory talks and about the various gradings of the angle and diagramming gonioscopy. So gonioscopy that allows us visualization of anterior chamber, and it is mandatory for management of glaucoma. And some very basic principle of gonioscopy: as light coming from the anterior chamber gets totally internally reflected, that's why we cannot see the angle structure. So once we keep a gonioscopic lenses on the cornea air interface gets changed by the lens air, and that's how then it changes the critical angle. That's what then permits us visualizing the angles. So just before going to the gradings of the angle, I think we should know the angle structures, and it is always better to come from posterior to anterior. So the root of iris, then some ciliary body band, and most prominent structure is the scleral spur. All those who do gonioscopy regularly, they will understand the importance of finding the scleral spur, because that is one of the very whitish structure and very easily identifiable, and that makes understanding gonioscopy, understanding the structure of the angles more easy. So this is the scleral spur. Anterior to that is the pigmented trabecular meshwork, and this will be more important whenever now MIGS and other things comes in the picture, because this is the area which will be important in identifying and putting all the MIGS devices there. And then anterior to the pigmented TM, there is a non-pigmented TM, and anterior to that is the Schwalbe's line. So these are the angle structures. So I will again stress the point that always whenever we are identifying the angle structure, grow from posterior to anterior. If something is not visible, but try to identify the scleral spur. So if angles are nicely open, then the root of iris, ciliary body band, scleral spur, then pigmented TM, non-pigmented TM, and then the Schwalbe's line. This is how the angle structures are, and it is better to always go from posterior to anterior, identifying the angle structure. And something basic like identifying the angle structure, Schwalbe's line, it is a termination of descendant membrane identified by locating the corneal wedge. So this is how there is corneal wedge. I think Dr. Satyan will show you a very good video about clinical gonio video. There is a narrow beam of light projected onto the cornea and narrowed to a wedge and beam from anterior cornea and posterior cornea. Where they meet exactly, there is the Schwalbe's line. Then the trabecular meshwork, it has two parts: anterior non-functional, which is non-pigmented, and posterior pigmented, which is functional part or pigmented TM. And just behind the pigmented TM, there is a Schlemm's canal, and Schlemm's canal will be visible, or blood in Schlemm canal will be visible only if there is a hypotony in the anterior chamber, maybe because of trauma, cyclodialysis, or raised episcleral venous pressure. So generally, aqueous once it is flowing from anterior chamber to Schlemm's canal and further into episcleral venous pressure. So blood will come in the Schlemm's canal only when the IOP is low on the anterior side in the anterior chamber, or the episcleral venous pressure is high because of CCF fistula or anything. So blood in the Schlemm's canal is seen sometimes with the contact gonio lenses once the episcleral veins are compressed, or only with the CCF or Sturge-Weber when there is a raised episcleral venous pressure. Now the scleral spur, which is a whitish structure, which is the anteriormost projection of sclera, the site of attachment of longitudinal muscles of the ciliary body, and it is seen as a dense white band, and one of the very important landmark is the scleral spur. Ciliary body is a dull brown slate grey band. Width depends on the position of iris insertion. Now there is the Schaffer's. Now we'll come to the gradings of the angle. Schaffer grading tells us about the angle and its how much it is open. So grade 4 is the widest open angles, around 35 to 45 degree. Grade 3 is 25 to 35. Then grade 2 is 20 degree. Grade 1 is 10 degree, and grade 0 is close angle. But see, Schaffer's method has only guesstimate. Like we say, okay, this is grade 4 angle, grade 3 angle. We don't exactly measure how much degree the angle is open. So rather than Schaffer's grading, Schei's classification, it shows about which angles are visible. So it says it is wide open when all angle structure are visible. Grade 1 when iris root is visible. Grade 2 is ciliary body is obscure. Grade 3 is posterior trabecular meshwork obscure, and grade 4 is only Schwalbe's line visible. And angle depth is based on the structure visualized. Again, this also is a reverse of the previous one, so that's why this is also not a very commonly used one. And most commonly used is a Spaeth classification. So it not only it considers angle width, it considers curvature of the peripheral iris and the points of iris insertion. So it exactly tells us grade 4 means all the angle structures are visible. Grade 3 means here you see the ciliary body band is getting obscure and you see only scleral spur. Grade 2 means even the scleral spur is also not visible, and what we see is pigmented TM, anterior non-pigmented TM and Schwalbe's line. Grade 1 means even the pigmented TM is also not seen, and grade 0 means almost you can see that this corneal wedge is not coming to the from the posterior and anterior side together. So even Schwalbe's line is also not visible. So this is a close angle. So this generally nicely explains, and this is what is most commonly used. And then the curvature of peripheral iris, whether it's convex, whether it is straight or with queer. So that again tells us about the iris configuration and point of iris insertion where it is in the ciliary body. So this is what are the recorded data. Whenever we want to document the gonioscopy finding, the configuration of the angle, depth of the angle on the basis of the posteriormost structure seen in that quadrant, then the shape and the contour of the peripheral iris, and the degree of pigmentation, mild, moderate, or heavy pigmentation, and presence of any abnormal structures like peripheral anterosynechias, any NVA, any angle foreign bodies, or anything. So this is how we record the gonio findings. And these are the videos of these are the photographs of the indentation gonioscopy where no angle structure is visible, and once we indent that, if there are no any synechias, angle structures will become visible. So this is what, this is before indentation when we can't find the angle structure, but once we indent, we see that almost angles getting opened. So then whenever we document the finding, we have to document that also, key what is before indentation and what is after indentation. Now coming to the documentation techniques, simple techniques are just marking a cross and marking a circle on that. So these are the ways most commonly used gonioscopic documentation, which most people do in their practice, in their case sheets, in their EMR, electronic medical records. That's how it is easily available. So here how we, the posterior-most structure is recorded inside the circle. Now this is inside the circle, whatever structure which is posterior-most, like Scleral Spur or TM or ciliary body. So inside the circle we document what is the posteriorly-most structure which is seen in that area. Outside that structure, the level of observable pigment is noted and any other relevant findings. So whether the pigment is there or how much it is there, and any relevant finding, like see from 4 o'clock to 6 o'clock or 7 o'clock, you see any angle recession, any peripheral anterosynechias, any NVA, any trap fistula at the 12 o'clock position. Whatever finding you want to document, you document outside the circle. Inside the circle, you just write the posterior-most structure which is visible in that quadrant, and generally this gives us sufficient information to document, which will be useful for future findings. So something similar, key you can write like this, key what is structure which is visible in that area. Any specific finding also you can write, key which areas there are any peripheral anterosynechias. Another one that is recommended is the Becker's goniogram. This also is an interesting this thing. So as I told you, the scleral spur is the most important structure. So this dark circle represents scleral spur, and then there are 3 circles outside and three circles inside that. The central dark line represents the scleral spur, and 3 lines outside the dark line represents trabecular meshwork. The 3 lines inside the dark line represent the various levels of iris insertion in the ciliary body, and the color code is provided for recording the findings. So this inside 3 circles are for the root of iris insertion, outside 3 are for the pigmented trabecular meshwork, and any peripheral anterosynechias, any long iris processes, anything you can draw in these lines, and inside you write where the iris is inserted and how much of ciliary body is visible. So this also is a recommended thing, but not very commonly used by all the centers. So this is how we document the gonio findings for our future comparisons. So this is what is a Becker's goniogram. So if there is any specific finding there, any growth there, any blood clot, anything, any cyclodialysis, you can write behind the scleral spur. And if there are any big synechia which is almost crossing to the pigmented TM and all, then it will cross this line, which is scleral spur line, and will come anterior to that. So this is how, if we document the gonio finding, that will be useful in our clinical decision making, because with the comings of other mixed surgeries, classification of glaucomas, other things, gonioscopic finding documentation, and further following it up in an institute where there are multiple glaucoma specialists seeing that, then documenting that for the future reference of the other specialists. So it is a good thing to document the gonio finding for the future reference, and it is indispensable for glaucoma management of glaucoma. Thank you.